Mm-hmm. People smile a
Sir?
lot. They say people smile a lot, but they wouldn't mind deal with you if you have issues.
Exactly. That's the way it is.
And
Yeah. So we quickly look at this one and we are done with this. You're the one that is discussing this part. Um, oh God. We are network is wow. I hope I'm not gonna have issues with I want to restart my system. Okay. So review the case, sir. Let's ask a question. Very good. So tell us about LCIS.
thank you. Sounds else. Can you hear me?
Yes.
We've talked about the type, florid, pleomorphic, classic, haven't. So differential and clinical implication, multifocal and bilateral tend to occur in multiple focal and often involve both breasts. Then the mark of risk, mark of increased risk for developing invasive breast carcinoma in both breasts, not just the site of origin, and the invasive ducta is commoner. Uh, Comparison to other lesions, it's bed ductal hyperplasia, similar to SCIC in terms of being a marker lesion, though less extensive in risk. Then ductal carcinoma is said to, unlike SCS, ductal carcinoma is generally associated with an bilateral risk for breast cancer. SCS is risk for both. The relation between atypical hyperplasia and SCIS, both lesions are composed of similar appearing disc cohesive cells. Then quantitative criteria, ALH, involve less than 50% of terminal ductal lobular units, incomplete lobular distension, and often shows admission with normal luminal cells. SLS shows complete lobular distension, but normal populations, such as certified vascularization in discursive cells. Okay. So the difference between the two now, okay,
Between what?
between ALH and LCIS, the degree of distension is important. It's more in LCIS. I mean, the degree of lobular distension is more in LCIS than ALH.
You know, ALH is actually the lobules. You see a lobular unit. Part of the lobular
Mm,
unit is involved by these typical discohesive cells. But the other part is spread. Now, when you have more than 50% of the lobule being involved by this neoplasia, that's LCIS. If it's less than 50%, that's ALH.
mm.
You understand?
So, yeah.
Let me show you pictures quickly. Look at ALH, atypical lobular hyperplasia. Let me see if I can find a good picture. What is this? This is plasia of breast. I'm getting wrong pictures. Load LH. Let's see LH. You see, this is a terminal ductal lobular unit. These areas are all involved already. I would say, let me see if I can get. Uh-huh. It's not very distended also. It's involved, but not very distended. Let me see.
Then also it's like it's not monomorphic. The cells population that make all the aplasia is not monomorphic.
They're usually monomorphic. Maybe the
Oh.
normal side will make it polymorphic. You know that if it doesn't involve everywhere, some parts will not be involved. The thing is this, usually it's not going to be like the word distension is also a very important word. I agree with you now, 100%. Because sometimes it will not be distended. You will see the thing under the microscope, it will look small. Do you understand? It will look small. But when you see LCIS, LCIS will look big, huge, usually not that small. Look at this. If you look at this, you see all these places involved. Maybe here, I don't know, but it's going to look small. For LCIS, you can see it's not very distended. Look at this small lobule, small lobule, small lobule, small lobule. There are many of them involved by the tumor, but they're not very distended. But when you start seeing, look at this ALH versus LCIS. Eh, I don't know, it's kind of difficult. It's still difficult for me up to now. Look at this ALH, LCIS. It's a very huge lobule here. Let me see if I can make it larger. Sorry.
Darling, so one day.
Okay. Ultimately, we don't have that here. But let's see. So this is it now. Let's see. Look at this. You can see how distended this is.
I can see your screen.
Can
Okay,
you,
sorry.
can you see it now?
Okay. So don't worry. I can see it.
Can you see how
I
distended?
can see.
Can you see how distended this area is? Very huge.
Mm-hmm.
Very huge.
Mm.
These lobules are huge. But look at the ALH. They're atypical cells, but they are still almost the size of normal lobules of the breast. Okay. Remember that you will differentiate them from DCIS by Ikaderin. I don't know if you get me.
Mm.
So the LCIS is huge lobules, you know. Uh, so that this ALH, the lobules are still small. If you do LCIS, let me give you a picture of LCIS and then okay, look at this. You see AL, look at normal lobule. This is a very good picture. Look at normal lobule. Can you see the size of normal lobule?
Mm-hmm.
Let me see if I can isolate this. Oh wow, sorry. Uh, oh, sorry. I don't know why it's not showing. Unfortunately, it's not showing. Good. So if we can make it larger, that would be good. Uh-huh. Look at this. Normal lobule, small size, very clean cut, just two layers, luminal and epithelia. Look at this. It's expanded, more cells. You don't see you don't see the well-structured two layers, right? But what are the size of the lobules?
Sorry, I got interrupted. The ones on the right, the lobar SCIS is more distended now.
Very good, significantly
Mm.
distended compared to the what? ALH. Compare the ALH to normal. The normal ones have lumen. ALH has no lumen. Cells have filled up the whole lumen, right?
Yeah, yeah.
But at least they are still small sizes, a little bit bigger than the lobular units of the normal lobules. But look at LCIS,
It
distended.
has filled up. Yeah.
Yes. And the distension measures more than 50 cells across. What would that be?
More than 50 cells. That's SCIS, right?
LCIS, more than 50 cells across will be florid LCIS.
Okay.
You remember we have florid LCIS, more than 40 to 50 cells across. But if they have significant pleomorphism, that will become what? Pleomorphic
Pneumothorax.
LCIS. Okay, good. What's the next now? Continue.
Picketed spreads may spread along ducts in a picketed fashion, causing appearance of a lumen. However, the lumen is lined by non-neoplastic luminal cells, not neoplastic ones. So you now have the neoplastic cells sandwiched between the basal the basal membrane and the sorry.
Yes, people membrane, microepithelial cells, and luminal cells.
Okay, yeah.
You remember that? Very good. Remember the clinging type LCIS? Can you describe the clinging type LCIS?
Well, I can't remember, but what I remember, printed side. Uh, is it like
What is this? Is this LCIS or ALH?
ALH?
Why?
Um, the degree of distension,
Yes.
but is it more across? I don't even know. I don't think it's up to 50 cells
No,
across.
we don't even ALH is not even LCIS. Look at this. Look at compare. These are normal ductules, lobules here for comparison. These are slightly distended. These they look very lobular. You know they are neoplastic. Okay, compare it to this.
Hmm. Yeah, yeah.
Is this ALH?
Yes, that is it.
Is this ALH? ALH.
No, 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 no. It's LCIS.
What
There's
about
even what look like calcification inside.
yeah, the have necrosis and calcification. That's the fluorine type. Can you see? Is this ALH or LCIS?
LCIS.
You see how distended. Compare it now to this again. You see these signet ring cells, kind of cells. You see these neoplastic cells, monomorphic cells. No more 2 unit. You don't have luminal and epithelial layer. So this is pure ALH, right? ILC, this LCIS. So let's look for. So clinging type, I can't find. Okay, well, here, look at this. This is the purgatory type you were talking about. Yes, it's
Hmm.
sandwiched. But I'm looking for the clinging type LCIS. We saw it last time now, right? I don't know exactly where we saw it. It usually involves ducts.
Lines along the ducts. Maybe
Yes,
it's going to line along the ducts.
yes. And just the purgatoid one, my challenge now is that the purgatoid type also lies along the ducts too.
But that one is around the lobus,
Yes, you're right, you're
lobus.
right. The clinging type looks like actually it's their ducts, but oh, it's not LCIS, it's DCIS. I'm getting more confused. Is it LCIS that first clinging type?
Well, you could check, but if it is clinging, maybe it's going to be along the dust. Because most of the time, when something is clinging, it's what you have in your blue line. Like you now have or you have something like a branch of a leaf. You now have something that hangs along it, or a
Hmm.
branch of a tree. like you have an umbrella, you like no umbrella branches, and then you have something that clinges, lines and all. That's actually the description. I can't remember which one now. Most likely it's going to be DCIS.
Mm, I'm looking at LCIS now. I can't find cleansing type. I think the cleansing type should be LCIS. Let's see. Hey, look at it. It looks like, let me see. LCIS with clove like leaf pattern. I think this looks like a pagetoid one, I would think. Let me see. LCIS with preserve architecture. Pseudopapillae. Apocrine features. ALH with apocrine features. It's ALH. Apocrine features. DCIS and LCIS coexisting. This is papillary, micropapillary DCIS. Remember the tiny beads, the expanded head, hyperchromasia here, the expanded head, pleomorphic LCIS. I guess that thing should be under DCIS, clinging type DCIS. DCIS, let me see. Does it have any clinical benefits
Also,
or clinical significance? Sorry, non benefit. This is look at it. Clinging pattern. It's not what we saw last time.
what did they write about the thinking pattern now?
They say DCIS negative for ER and HER2 is rare and often difficult to recognize. This case of a subtle DCIS adjacent to a BRCA1 associated invasive cancer is only recognizable due to high nuclear grade. The associated lymphocytic infiltrate is commonly seen. Um, I'm not sure if you can put it in picture. We just ask it if you can't find it. I'm almost not also finished schooling. Papillary pattern. Yeah, look at it. This is exactly what we're looking for. Clinging pattern DCIS consists of cells with high-grade nuclei, lining spaces without filling the space or forming architectural structures. This is clinging pattern DCIS. It's not LCIS.
Okay.
Very pleomorphic cells in spaces, not filling the spaces, and looking like having some hobnailing. Usually adjacent to you have adjacent to normal DCIS. What's the significance of this clinging pattern? They usually have high nuclear grade. Do you know anything about the
They have what?
high nuclear grade?
Okay.
Did you see the picture I showed you?
I saw it.
Clinging pattern DCIS. Let quickly see. It's a subtle architectural variant of DCIS in neoplastic epithelial cells. They replace normal ductal epithelium in flat, the non-proliferative manner. Normally, DCIS proliferates and fills the whole duct, but this one doesn't fill the whole duct, clinging to the basement membrane without forming the overt architectural patterns like cribriform, papillary, or solid types. The flat line of a typical epithelial cells adhering to the ductal basement membrane. They have cellular atypia. The lumen is largely preserved. There's no epithelial stratification, like here. Significant atypia, one cell atypical lining the basement membrane, no stratification. Necrosis is absent. Classifications are not present. ER positive, HER2 mu negative. KR67 may be present at times and all that. Then example, ADH, flat epithelia. Hey, we saw it when we were looking at flat epithelia atypia, right? Remember, what's the difference between flat epithelia atypia and they have apical snouts, right?
Yeah.
Have stratification usually greater than 2 layers. Am I right?
Yes, 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 yes.
Do you remember more things about flat epithelia atypia?
Mm, Epic snouts. It could be. Is it not associated with columnar cell changes?
Yeah,
Yes, it is.
the columnar cell changes that have more than 2 layers is called flat epithelia atypia. Remember, we saw something like that. You can see columnar cell changes should not be more than 2 layers thick. Naturally pick up basement membrane. When they are cuboidal cells, dilated in sinus, and 2 layers or more, atypical cells, they become atypical cells forming multiple layers. That's flat epithelia atypia. Okay, let me see. They usually they have lots of nuclear polarity, multi-layered, rounded monomorphic appearance, punctate nucleoli, necrosis. You remember this? This was where we saw it.
Okay.
We say that flat epithelial atypia may mimic clinging type DCIs. The difference is that flat epithelial atypia does not have high-grade nuclei. Where you see a duct that looks like atypical and has high-grade nuclei, significant pleomorphism and mitosis, don't call it flat epithelial atypia. What should you call it?
This is clinical type.
Yeah, it's considered clear declining type. And you see them like brick layer, dilapidated brick layer walls or something. Now you see in what skin disease again? You remind me again.
Early disease.
Haley disease, also known as what? Forgotten the other name. So is this LCIS or ALH?
This LCIS
Very
is
good.
the standard.
Yeah, the standard, what is standard more. Okay. Okay, so that's it for that. Differential diagnosis is flat epithelial atypia, sure. For this, but this ones have apical snouts. So
Mm.
let's answer the questions and we are done. The next question we're going to look at is okay, let's look at this. Let's answer this one quickly. Which of the following best describe the distribution pattern of lobular carcinoma in situ?
Multifocal bilateral.
LCIS is primarily considered as
I got this see very well.
Let me check.
Okay.
LCIS is primarily considered a what?
Mark of exclusion for invasive carcinoma, invasive cancer.
Yes. LCIS is similar to which of the following terms in pattern of associated cancer risk?
Mm-mm. Ordinarily, I would have said CIS, DCIS. Okay, they both have pattern of bilateral
Yes.
ADH.
Mm.
But if you look at it in terms of increased risk, in terms of pattern, it's
Yeah.
ADH. But as regards the risk,
Is this
it's
CIS?
DCIS. 8 to 10, 8 to 10.
Let's say pattern. No, they didn't just use the word risk. Pattern of
Yeah, yeah, yeah.
but it's still dicey. I agree with you. It's not a clear-cut answer
Mm.
or question. Which of the following features favors its ALH over LCIS?
Less than 50% of the lobes.
Okay. Which of the following histologic features is characteristic of LCIS?
Intracytoplasmic coagulation.
Yeah, that's what they call the signaling cells. In
Yeah.
LCIS, apparent residual lumina are usually
Non-opacity luminescence lining spaces.
that's the purgatory type, purgatory spread of LCIS. So you have luminal cells. Normally they fill up the whole lumen. Unless they when they evolved or they can perform purgatory spread. Which of the following best describe purgatory spread in LCIS?
Spread along dots with luminal lined and non-opacity cells.
Which features distinguishes LCIS from ALH most definitively?
Enter the terminal dot globular unit involvement. That's greater than 50% LCIS.
And so LCIS will involve more than 50%, while this ALH will probably like 60-50%. I don't seem to really agree with this because some of the pictures they show us are just the whole terminal ductal lobular unit is involved, but they are not distended. So I'm not so sure about this. But I would say is it extent of involvement. I would say distension is my main go-to. What histologic feature in LCIS can mimic luminal formation?
Intracytoplasmic coagulation.
Okay. Mm. Which immunohistochemical marker is typically strongly positive in LCIS?
Keratin. But which of them? Is there molecular weight? Yeah. 5 and 6.
What is this? What's another?
That's cycle keratin 5 and 6. High molecular weight.
Uh, I'll move ahead of it. I heard of it, but I did. I've forgotten that is the one. Okay. Mm. Target 5, 10, 14. I don't know. 13, 34, beta E 12. Mm. What is typical E calorie status in LCIS?
It's negative.
I've not seen anybody using cytokeratin to diagnose SCIs. But for 12, my senior guy that wrote the exam this year, he just wrote the exam this week. He said the exam was hard.
Mm.
I don't know, so I have to really sit up, man.
But it's still objective now.
It's objective. But I know that just like USMLE can be objective and still be tough. You understand?
Mm.
So objective doesn't actually mean that the exam is going to be easy.
Yeah, I understand. I understand.
Sometimes, any exam can be hard, no matter the format. So what term do authors use to encompass ALH and SCIs due to diagnostic overlap?
Lobular neoplasia.
Hmm. That means somebody once said something in one lecture. Why is there so much overlap and difficulty in different? I'll paraphrase using his words now. Conrad Fischer now.
Mm.
Why is there so much confusion and it appears as if there's an overlap and difficulty in differentiating ALH and LCIs? Can you tell me why? You see the answer
Then
is
the compose is just the degree of the compositing cells may be similar,
you
but
see,
it's the degree of extension and
you see the answer is because there's an overlap. The way talk is politics. That's why. So these are not convoluted. Why?
but Conrad is an internal medicine person.
Yes, I'm using his words. There were some things we were describing in internal medicine. They seem so convoluted. He said, "Do you know why they are so convoluted and difficult to really place here or there?" He said, "Because they're actually convoluted and difficult." So that's why. So ALH and SS sometimes it's difficult to differentiate. That's why authors now use the word like lobular neoplasia. You want to
Neoplasia.
find it out, and you're not too sure. You can write lobular neoplasia for your consultant to go and fight. In real life, sometimes these things are not as clear cut as we see on the pictures here. They give us the best pictures, right? So sometimes you'll be like, just call it lobular neoplasia. Then you can read and P120 to be on the safe side. The pathology is where, I used to be so confident in when I was in internal medicine or medicine. Pathology is where you decrease your level of confidence. So you just try to be as general as possible to give room for other people to come in and work it up. I mean, I'm not sure. Even some of the text said they say we should not sign it out alone. Which of the following is a rare feature that may be seen in the variant of LCIS?
Which of following machine variant is commit type necrosis?
In florid LCIS, remember?
Mm-hmm.
Sometimes not all community necrosis means automatic DCIs. Although
Okay.
I can bet you that in real life, there are a lot of pathologists who would have seen LCIS as community necrosis and they'll call it DCIs. I'm telling you, I'm not I'm not joking. Unless they can differentiate it by stage and they won't know.
That would
That
lead to over treatment now. Abi?
yes, yes. I think LCIs is generally no, I don't know. What's the management of LCIs, by the way? That's one thing we didn't focus much on. And they can ask it in exams.
SCIS, I think it's just excision.
What kind of excision?
Mm.
They didn't even tell us about treatment here. After we asked what the treatment of LCIs compared to DCIs. Okay. Because that helps a lot. You know, do you know that you need to know treatment as a pathologist?
Eh?
Do you know you need to know treatment as a pathologist?
We don't used to do treatment.
We are supposed to know treatment
Yes, we need to, yeah.
because there was a case. I think somebody went to frozen section. We are doing a lot of frozen section, and they
Mm.
sent a case. and the person did not know that, person took it for granted or something, that if you say yes, that meant amputation. Person did not know. I think person took it for granted. Now imagine you casually saw it and you are not sure. Then okay, let's just defer on the side of yes. Now amputated, the same permanent section and it's negative.
That, that is
You see?
that's that's a risky decision.
That's why you need to know the treatment. So when I go with my attending sometime, I ask my attending, why are we here? What will our decision impact? How will our diagnosis impact the clinician? So sometimes they will call the clinician and say, what do you want to know? If it's a very high stake decision, they will not call it. You know what they will do? They will describe it and say defer to permanent section. Allow it.
Defer to permanent section, abi?
Yes. They just describe something, they'll use very generic terms and say defer to permanent section. Do you understand? Like
Mm.
neoplastic, discohesive neoplastic cells, suggestive of LCIS. However, these cells cannot be ruled out. Defer to permanent section. You see that kind of
Mm.
tricky, legalistic way of wriggling out of something. And you are not, it's not a crime for you not to call something correctly. The problem is, I know that in pathology, they count one of the things that there are three things they use for promotion in my program for pathology attendance. One, um, I've forgotten now, but one of them is the number of concordance between frozen section, things that can strike you. They count the number of concordance between frozen section and permanent sections. If you have a lot of discordance, your job will be at risk. So you have to make sure that whatever you are calling, when it comes to permanent HRD comes out, it corresponds to what you are saying. So they are very skeptical of that. Number two, amended reports. Every time you amend a report, it counts against you. So people are so scared of amendment. So they want to make sure that whenever they sign out a case, they are very sure. They show their colleagues everything because the clinicians call back or something happens and they have to amend it. Somebody look at it, it counts against you. I think number three, I forgot number three now. So you have to be job markets, I'm just maybe I don't know, maybe this happens in the UK. I'm just trying to let you know so that when you get it, you have to be very aware of it. In contrast to LCIS, doctor carcinoma in situ is most often associated with what?
Natural risk for a basic
Yes.
person.
Which statement is true regarding cytokeratin 34BE12? Found in UDH and LCIs, but variable what? In ADH. I never saw such a thing here. Now,
It's also the doctor application on this slides.
I can't hear you very well.
So they say strong in usual doctor aplasia and slides.
Yeah, variable in ADH, yes. Look at the management. LCIs is mainly incidental and doesn't form classifications on X-ray. Rarely. DCS is mainly due to classifications. Management, observation, and follow-up. You are right. So no surgery is typically required for LCIs. What other things can you do for LCIs, for classic LCIs? Endocrine therapy like tamoxifen, raloxifene, mammography, MRI, surgical excision. If you are suspecting that cancer has already formed, but not recommended. The only time you do surgery. For what was the only time you do surgery for LCIS?
Hmm.
Look at it here. It's here. Second line.
Found on core biopsy and they are concerned for upgrade to carcinoma.
No, no, no. Here, look at here. Surgical.
Not recommended as a not recommended as a rule unless pleomorphic SCIS or comedo necrosis
Yeah,
present.
you don't remove LCIS breast unless there's comedonephrosis, necrosis, which will call it florid LCIS or pleomorphic LCIS. Okay, good. Okay. Yeah, but for DCIS, we even do radiotherapy if you have lymph nodes or something. I can't even remember. Yes, I think there's so the radiotherapy we do for DCIS, right? If you have lymph nodes. So let's go to the next question.
Okay, the next question.
Mm.
I'm still using which of the following elements regarding mitochondrial breast is true? I, right now, we can look at the following question, right?
Yes, we have said already. Yes.
Which of the following regarding
After this, please you will join me. Are you free next week?
I don't know yet.
Mhm. I'll say C is my answer.
Uh, I'm not even very sure.
I'll say E. Either C or E. I'll say E.
I will say D, Sha.
Mm.
I say D.
I'll say E. Final answer is E. Let's quickly review it and see.
Ah, no, sorry, let me confirm.
Okay. Mm. You see C is the answer. Let's see why D is wrong. D is wrong because true medullary carcinoma requires greater than 75% syncytial growth, not less than 75%.
Yeah, not less than. Although it's familiar. Sorry, I'm confused about that. Which one is the answer? One must apply. All other things in it are correct, abi?
The answer is C.
Except
That a lot of them how I chose before that went to E. I'm
one
wrong.
must apply Sukawa for a diagnosis and following is compatible with the venue. The diagnosis of health is coercive and provided. Ah, that's true.
It was that.
75% sincere growth.
Yeah.
Not
More than 75.
okay.
Mm. Not when the lymph node was not crowded out. Atypical medullary carcinoma has a worse prognosis than typical. Mm. Okay, let's go ahead. Mr. Chat is correct. You know, they now call it carcinoma with medullary pictures or something.
Yeah.
What do they call it? They call it now invasive ductal carcinoma of no special type with medullary features. I wonder how many things we have to. Let me see how many things we have here. Okay, not much. Thank God. So let's review it and then I'll do that. Then you look at the last part and then I'm glad that I'll tell my. I think I'll have to upload all these videos and send to you. Please be watching it when you are free.
Send it to me.
You will be surprised that you will so master breast and you'll be surprised. And people will wonder how come you know breast so much. If you can do all this for the videos over the next 2 years, I can pass my exam. After this, I'll start doing the ones I've done so that will be faster. What do you think?
That's good.
Because that one I already done it before, so it'll be faster and then it'll be like revision for me.
Okay. Have you done gynae?
I've overdone gynae.
I want us to do it.
That one is the one we can do again. It's not just about doing the diagnosis, also things surrounding the diagnosis. That's the
Mm.
issue. That's what makes you pass an exam and also even survive. It's not just easy, it's not just about doing the diagnosis. You have to know the politics around it too. Terminology and evolution of classification. What's the historical name for this disease?
Well, medullary carcinoma.
Other people call it atypical medullary carcinoma. Some people call it carcinoma with medullary features. What's the new name now?
Invasive NST with medullary fistula.
Invasive ductal carcinoma, we are right, of no special type with medullary features. Wow. Invasive ductal carcinoma of no special type.
Mm.
IDC-NST with medullary features.
Mhm.
After the WHO fifth edition update, this group is no longer recognized as a distinct histologic subtype, now categorized under what is TIL? What is
Yeah, rich invasive carcinoma.
Hmm? Tumor infiltrating lymphocytes. That's what it means.
Okay, yeah, rich.
Categorized under tumor infiltrating lymphocytes rich invasive ductal carcinoma of no special type. The change reflects the understanding that the immune microenvironment, particularly tumor invading, tumor infiltrating lymphocytes, drive the unique behavior of these tumors more than their architecture. TILs drive their behavior more than their architecture. They go to microscopic and morphologic features. Classic histologic features of invasive ductal carcinoma medullary pattern. Invasive ductal carcinoma medullary pattern. Cohesive syncytial growth. Greater than or equal to 75% of tumor.
And well circumscribed. Hello?
Yes. So the cohesive cell group of greater than 75% lacks depth of sheets of high-grade cells without gland formation. So the cohesive growth must be what? More than 75%.
25%.
More than equal to 75%. Can they form glandular structures? No, they
Okay.
can't. And that means already from, if you want to do Nottingham grading system, it's already high grade from the beginning. You cannot find tubular structures. They don't find glands. They are well circumscribed or pushing borders. So they don't have a filtrative pattern. So that's one thing. If you look at this looks well circumscribed. If you look at this tumor here, look at it here. They must have well circumscribed or pushing borders. What do you call pushing borders? What's a pushing border?
Mm, you do not interchangeably with circumscribed nature.
You look at this like pushing. It's not as round. It's not some, at least some areas want to push out, but they are not, they are still contained, right? So areas
Mm,
want to push out, but they are still contained. So they have cohesive. So then finally, there are 5 criteria, and I'm going to ask you the cruise criteria. So excuse me, senior Talkman, please help me with the criteria for those. So pay attention so that you don't disappoint your boy. Um, what? Just a minute, please. Anyway, let's continue. So the third one is there must be prominent lymphoplasmacytic infiltration. And the prominent lymphoplasmacytic infiltration must be both intratumoral and peritumoral. It must be both what?
intertumoral and peritumoral.
Intratumoral and peritumoral. It must be both what? Intratumoral and peritumoral.
Tumor.
So number 4, there must be high nuclear grade and mitotic activity. Number 5, there must be involvement of surrounding benign the ducts and
It may not be, it can be seen, not necessarily, it may be, it may be absent. But the
agree.
other four, it should be present.
Yes. So mention the criteria for diagnosing the disease. First of all, mention the name of the disease and the criteria for diagnosing it.
Okay. So the disease is inclusive doctor and carcinoma of no special type with medullary features.
Mhm.
The part of tumor, sorry, I forgot to irritating lymphocyte rich and irritating daughter carcinoma. So the criteria is cohesive syncytial growth. That will be up to greater than 75% of the atypical cells. So then also high grade nuclear, high grade nuclear, they have circumscribed or pushing border and tumor infiltrating lymphocytes, which could be intratumoral or peritumoral. Then it involve some of the logos. That's the number five.
Okay. Okay, good. So these features resemble medullary carcinoma, but are now interpreted within the intraductal carcinoma non-spatial type spectrum with immune-rich tumor. So let's go to immunohistochemistry. What is the most common IHC pattern?
Triple negative.
Triple negative. That's why I feel that E. I was thinking similar. So it's not the it's triple negative, ER, PR, 2 mu negative. They may sometimes show focally weak AR, PR positivity in a minority of cases.
Hmm.
They have basal-like cells immunophenotype, like P. cadherin, the CK56 positive in 94%, CK14 positive in 12%, SMA positive in 34%, EGFR positive in 71%, S100 positive in 100 in 44%, P. cadherin positive in 87%, P53 positive in 46 to 86%. So pick at heroin and all that. So let's go. So let's continue. So let's go to immune markers. Immune markers include increased CD8 positive cytotoxic T cells, activated HLA-DR positive T cells, and all that. Anyway, molecular pathogenesis. These are like phenotype. Remember that when we discussed triple negative cancers, medullary was one of them. Basal-like phenotype. Basal-like phenotype on gene expression profiling in 95% of cases.
I think is it not this like profile that says CK56 and EGFR?
Yes. Ah, the team was studying one part of the corpus callosum and needed the one part of the brain needed corpus callosum to cross connect it. So basal-like phenotype, that's why they are EGFR and CK56 positive. Immune response, apoptosis, antigen presentation related. Genetic features, BRCA1 mutation. BRCA1 mutations are associated with 30 to 60% of the cases. Are you there?
Yeah, I'm there.
Okay, 30 to 60% of the cases, BRCA1 mutated tumors. Wow. 25% with BRCA1 somatic mutations. TP53 is most common somatic mutation, followed by BRCA1. Clinical presentation. What's the age of the people with medullary carcinoma?
Younger women.
Younger women, and the mass will be rapidly enlarging,
Largely.
palpable mass. And they have axillary lymphadenopathy that can be either reactive or metastatic. They are managed similar to triple negative breast cancer with PD-L1 inhibitors like atezolizumab, PARP inhibitors for BRCA mutated patients. Prognostic and predictive biomarkers. We have TIL. What is TIL?
Tumor infiltrating lymphocytes.
Infiltrating lymphocytes. Tumor infiltrating lymphocytes are predictive. So biomarker of chemo response, especially in the adjuvant setting where they do chemotherapy before surgery. So high TILs, looking at high TILs have greater than 60% post-therapy better survival, and they correlate better with metastasis-free and overall survival. PD-L1 expression is seen in 38% of. Oh, we used to do PD-L1 in my hospital. It's an IHC. I don't know why they do it. Maybe it's for triple negative cancers in general. It's seen in 31.
It also there are some treatment that are also based on PDL1,
Yes.
like PDL1 targeted immunotherapy.
Yes.
Hmm.
What is PDL1, by the way? What's
Mm,
PDL1?
I know it's a form of antibody.
Oh, what?
I've forgotten. I know they use it in a number of cancer. They use it in lung carcinoma, lung cancer. I think it's a form of antibody.
Yes. Let me show you. It has to do with, I think, apoptosis or something.
Okay.
This death of
Okay. Okay. Okay.
cancer cells. Oh my goodness. Let's see if I can find. Look at this. So PDL1 is normally found where? In the tumor cell. Okay. Why PD1 is found, I think, in the lymphocytes or something like that. So when PDL1 binds to those lymphocytes, they stimulate apoptosis or something. So PDL1 knockout. Let me see. So you see PD1 is found in the lymphocytes. Now, so lymphocytes go to the tumor cells and bind their PD1 to the ligand is PD1 on the lymphocytes. PDL1 is on the tumor cells. By this binding, they activate the tumor cells to kill themselves. That's why the more lymphoid tissue you have, the better the prognosis, in this PDL1 something. So how does the drug work? Atezolizumab.
That means it should be the apoptosis now, like induce apoptosis.
Yes, I'm trying to see. This is the T cell now. T cell has okay. So this is let me quickly ask Mr. Chin. Mechanism, because we're going to exam, they'll ask you. And I'll be like, I had to put him to read it too, and I didn't read it. So PD1 is found on the activated T cells. PDL1 is expressed on tumor cells and some immune and non-immune cells. When PDL1 binds to PD1, it promotes the ah
Hello.
oh, I get it. They get it now. Wow.
PD.
Normally, T cells kill tumor cells. This is a T cell, and this is a tumor cell. So how do tumor cells evade killing? They use their PD-L1 receptors to bind to PD-1 on T cells and cause the T cells to undergo apoptosis. Either
Okay.
exhaustion or apoptosis. So the drugs come and block off the PD-1 ligands. The drugs are shaped to resemble the tumor PD-L1 because to block up the PD-1 ligands on the T cells, allowing the T cells to use the normal pathways of T cell receptor and major histocompatibility complex to kill the tumor cells.
Okay. By cheating.
Yeah, it will now cause the tumor cells to undergo apoptosis. So the T cells has a mechanism of killing tumor cells, but tumor cells evade T cells by using their PD-L1 to bind to the PD-1 ligands or PD-1 receptors. So ligand is the PD-L1, sorry, to bind to the PD-1 receptors on the tumor cells. So drugs flood the PD-1 receptors and cover it up, preventing tumor cells from finding it, and they'll no longer be able to attack the tumor cells, the lymphocytes. And lymphocytes will not survive long enough to kill the tumor cells. So the more lymphocytes you have, the better the prognosis. Do you get this, sir?
Mm. The more lymphocytes you have, the better the prognosis. So because the tumor cells can no longer evade the apoptosis, right?
And no,
So,
that the T cells, T cells to
mm,
start from rest. Yes, the more T cells are meant to kill tumor cells.
mm,
So, but what prevents T cells from killing tumor cells in this kind of case?
it's because the PDL1 on the tumor bind to the PD1 on the tumor cells.
No, the
Sorry, on
lymphocyte.
the or the T cells.
Yes.
So you use the drug to mimic the PDL1 of the
Yeah.
tumor, and
Yeah.
then it bind to PD1 on the T cells,
Yes.
such that what the T cell now will now be able to activate apoptosis in the tumor. How does it activate that apoptosis?
It's normal immune mechanisms now, the majority of combative complex. The reason why you block it up is that it closes the binding site for the tumor. Not
Okay.
when the tumor binds to the T cells, it destroys the T cells, inactivates the T cells. But when the drugs bind to the T cells, it does nothing. It only blocks the pathway for the tumor to bind. Do you understand?
Yeah, I understand.
Yeah. So PDL1 expression on the tumor. So the PDL1 is actually what we're looking for it on the tumor. Do you know that my attending the other day, I asked my attending, what test should we order? Is it PD1 or PDL1? She was like, I don't even know anyone.
What test should you write?
Yes. We order tests, IHCs for the cases now. So
Okay, it will be PDL1 now.
yes. So but she didn't know. And she doesn't even know which mechanism is which. She just know the thing was just confusing her. She has forgotten all these things. So at least if you are an attending, you're able to tell the attending that, oh, it's PDL1 because PDL was on the tumor, right?
Yeah.
So which of them has IHC testing? And I don't know, I think there's PD1 IHC. Let me check, sir. I want to be sure that I'm not wrong. Which of them
It
can
should
be
be
tested?
PDL1, the one that's on tumor cells.
Yes,
But check.
yes. Is a commonly tested one, not PD1. PD1 expression on tumor cells or immune cells is used as predictive biomarker to determine the eligibility for PD1, PDL1 inhibitor therapy. You know that there's PD1 therapy, there's PDL1 therapy. This one can be tested in tumor in the maybe research. You can do PD1 testing in research, to test for lymphocytes on the tumor microenvironment. But commercially speaking, it's PDL1 that is used to check the response to checkpoint inhibitors. They call it checkpoint inhibitors.
Okay.
I don't know why they call it checkpoints. Then what I wanted to say. So there's a question you were asking. Yeah. How do PD1 inhibitors work?
Did they call it PD1 inhibitor or PDL1?
There are we have PD-L1 inhibitors and PD.
Well, I said that they will like they because they inhibit the binding of the PDL1 receptor on the tumor to PD1. They inhibit the PDL1 receptor from binding to that of the to PD1 on the
Yeah,
lymphocytes.
the
And
PD-1 inhibitors.
it will now help the T lymphocytes to kill all the tumor
I,
cells,
I,
maybe
I I
through
get it.
apoptosis,
I get it.
activate apoptosis.
I get it. I think that you're right. The PD-1 inhibitors will block the PD-1. While PD-L1 inhibitors will be artificial PD-1 drugs that go to coat on the tumor cells PD-L1, preventing the tumor cells from acting.
Okay.
So, wow, I get it now. So look at it. They didn't told us here. We didn't read it. PD-1 inhibitors bind to PD-1 receptors where on T cells, blocking interaction between PD-L1 and PD-L2. PD-L1 inhibitors like atezolizumab bind to PD-L1 on tumor cells and antigen present, preventing them from binding to PD-1. So it's either you coat this way or you coat the other way. In whatever you do, you kind of ensure that the T cells are now free to kill the tumor cells. Okay. Sometimes this may resemble lymphoma. So how do you differentiate from lymphoma?
The, I mean, the medullary features.
Medullary carcinoma. How do you differentiate it from lymphoma?
Well, you should be able to, even if it's sincere growth of those tumor cells.
Yes,
The
histologically it
tumor
can.
cells
But if
from HIV, you could distinguish them from HIV. But if one is confused, one can do
so what IHC, for instance, we use?
uh, what we should do on this CD20, and then maybe this, then let's say
No,
CD20 and
CD20
CD4.
for B cells, right? The first is epithelial markers. Remember, you are comparing lymphoma to an epithelial carcinoma.
Yeah, yes,
Writing
yes.
A1, A3. If it's positive, then this is not a lymphoma. If it's negative, then you can start doing CD45, CD20. You don't want to start
So,
with lymphoma workup.
okay, so start with like you can do CK5, CK6, right?
No, a most popular was not AE13 or CAM 5.2. The pan-cytokeratin.
Okay, everyone.
Yes, AE13 or CAM 5.2. Because not all cytokeratin tumors will test with CK56. So you use pan-cytokeratin that will pick up any epithelial tissue at all. So that one will, even though this one CK56 will work because it's a basal-like cancer, but to be on the safe side, only use pan-cytokeratin for any epithelial marker you want to use. A13. So if it slides up, then that's not this is not lymphoma. Because you want to start with lymphoma workup, you do a whole panel of workup. That will be wasteful. And some private companies will not like that. So you start with epithelial marker, say, is this epithelial or non-epithelial? If epithelial.
Okay, okay, I will ask maybe later after this discussion. Let me know how do they
How,
manage your laboratory? Is it privately managed?
no, it's a teaching hospital now. So everybody has their department. It's not like what I mean private practice is like when you go to practice in the outside world. Somebody has a lab, like Dr. Ogun has a lab now, and I employ you. Do you understand? There are private labs in the US. There are a lot of private, but like private partnerships, like different practices they come together and establish. You know that in the US here they have private hospitals.
Mm.
I do surgery, for instance. Now that private hospital, of course, it's not like Nigeria where you can easily establish private hospital. It's very difficult to establish a private hospital here. The standards, quality control standard is almost it's not here. You understand? Now, they have to employ surgeons, employ all those people. Now, those surgeons cannot operate unless they have set of pathologists that they are working with, especially if they are doing tumor surgery and all kind of things. So it's either they send to Quest Diagnostics. Quest Diagnostics is also like a company. So either they send to, so That's why pathology thrives here. Different local hospitals, we have maybe St. Bartholomew Hospital, they will have set of pathologists that work there, not the teaching hospital. So those are more or less like private institutions. They are there to make profit. The thing is that, so they all just to audit them a lot. So if you do a lot of testing and the insurance company feels that some of the testing you do is not worth it, they may reject it. So you'll not be reimbursed. You would have wasted the reagents and wasted time without being reimbursed. Do you understand? So insurance companies scrutinize a lot of things here. Insurance companies are there not to help the patient but to make money. They'll be like, they have a lot of information of what to do for each protocol for each case. So you want to decrease the amount of IXs you do and do the most minimum. And then you don't do panels unless they are very necessary. So you do like introduction to a panel. Once you do your AE13 and it's positive, that's epithelial cancer. You don't need to go ahead in the lymphoma pathway. But if it's negative, then you're now free to do a panel. CD5, you don't do only one, you do CD20, CD79A, CD19, B cell markers, CD45 for lymphoid markers, CD3 for T cells, CD5 for T cells, CD4, CD8, then kappa lambda for clonality, those kind of things. Then depending on the kind of tumor, you now start throwing in, am I CD5, CD10? You want to look at, am I dealing with follicular lymphoma? Am I dealing with, I will put B cell, am I dealing with CLL, mantle cell lymphoma, marginal zone lymphoma, all those things, CD23, CD21. I mean, it's a whole panel you're going to throw in there just to
So
catch.
actually, even that one too, your histology pattern can guide you on the biology.
Yeah, you're right. You now determine from the morphosis to morphology, you now know. Am I doing? If you're looking at plasmacytoid cells, plasmacytoid lymphoma, you want to look at CD60E, CD163 or something like that. Plasmacytic kind of cell, things like that. Okay. So you always have to consider both private practice also in mind because you don't know where you land. So there's way to do magical production of results with limited resources. They just want to make money. So what will help you survive is high knowledge base. Do you understand? If you have a lot of knowledge, you don't have to go. But if you don't know a lot of things, if you don't know many things, you'll be throwing panels. Everything, you'll be doing IHC will be your guide, not H&E. You don't know what I say H&E, you start doing pan. Once you see H&E, you start through panels. You'll be like, this person doesn't know what he's doing. So, okay, good. Positive for CD45. Okay, good. Let's be done. So we are quickly looking at this quickly. So look at this. Where's MP? What's MP?
This one?
Medullary pattern.
Okay.
This mammography.
You talk about modern pattern of there's no mass. But that's
I didn't hear you. I didn't hear
so I
you.
just look at like I know I read what they wrote that that's the normal
Okay, okay.
pattern.
So all this here
Yes,
on
sir.
blood psychology.
Well circumcised up to find lobular mass, lobulated mass.
Whole mount section. Have you seen the whole mount before?
Yeah, I've seen yes, sir.
This,
If you
this
if,
thing,
if like leave some of the lymph nodes sometimes.
no, I mean whole mount for prostate. Do the whole mount for prostate in Nigeria.
Not usually.
They have a very huge slide like this. It'll be not like usual slide, very big that can contain the whole cut surface of a prostate gland. The inflammatory infiltrates, and typically see that the advancing age of the tumor. Syncytial growth pattern separated by thick fibrous stroma. Septa infiltrated by inflammatory cells. The fibrous stroma is infiltrated by inflammatory cells. Syncytial tumor growth pattern. Ill-defined edges and indistinct cytoplasmic borders. Prominent tumor infiltrating lymphocytes. Mature lymphocytes and plasma cells.
Mm.
These cells can coexist with it. It's scary.
Yeah.
I'll leave that. What kind of lymphocytes are surrounding these medullary cancers?
That's the terminal centers.
T lymphocytes are the ones surrounding it. Okay. This is CD43. What marker is CD43?
CD43.
Before T cells.
Okay.
Okay. Okay. Next.
The third question in the log can resemble. Mm.
Okay, so this is metastatic cancer to the lymph node. If this is found in the breast, I mean intramammary lymph node, it can be very difficult to diagnose, right?
Okay.
Because you may start thinking, is this medullary carcinoma or what? Because you may thinking
Yeah.
this is epithelial cancer metastatic to the lymph node.
Yeah. This one is epithelial cancer metastasis to the lymph node, but you may misinterpret it to be a invasive. That means if you see it maybe on the breast now, especially in the upper outer quadrant of the breast, one could interpret it to be a invasive carcinoma of no certain types is medullary features.
Okay.
What's the difference here now? It said in a node to be confined by a capsule. The lymph cell is confined by a capsule. So in the lymph node, the lymph node are covered by capsule, but in the breast, the medullary features there's no capsule.
Yes, now lymph nodes will already have capsule. Like here, you see the capsule of the lymph nodes. Yeah. Do you understand? The
Yeah.
lymph node will have a capsule, but breast will just be since there's no capsule. That will help you know that this is a lymph node. So lymphoid aggregates. Okay. Hello, are you there?
And then
I was dozing.
hyper uses okay, I go to the benefit of
So sometimes you
body
may have
pressure.
lymphoid aggregate centers in this case. Basal cytokeratin like CK56 will be positive. We say that already, right? Because this is basal-like cancer. In how many percent we have CK56? 94%. EGFR will be present in how many? 71%. EGFR, this CK56 EGFR. And finally, P53 mutation will be present is mutant expression. Okay. Explain these answers yourself.
Okay. Okay. Middle person breast suffer estrogen negative and often progesterone negative, but frequently shows at two percentages is usually triple negative. That B is not correct.
Yeah, look at it here from here.
Hmm?
Look at it from here. The correct
And
statement.
yeah, that's what I'm looking at.
Mm,
Usually triple negative. Then medullary type breast, atypical breast type tumors are not seen initially with BRCA1. That's also not correct. 80% are seen with BRCA1. Progression of medullary carcinoma is equivalent to atypical. Doctor atypical medullary carcinoma.
mm,
Medullary
mm,
criteria include several system growth pattern,
mm,
consolidated articulture with circumcision, with an actual mark moderate lymphocytic sorry. Medullary carcinoma include less than 75% CCR growth. No, it's not 75% CCR growth. It's more than 75.
mm.
Because America is always together. Uh, no, but classic American has a better prognosis than atypical. Okay,
So
then the first
classic
one
medullary
must apply strict
carcinoma and
characteristics and the
it's
Portugal show.
atypical hybrid ductal carcinoma. Ah.
Hmm. Goodness.
So atypical medullary carcinoma has less favorable prognosis. So, okay. So the criteria again is Syncytial growth 75%, high nuclear grade, prominent lymphoplasma cystic infiltrate, well circumscribed or pushing margins, lack of granular structures, triple negative phenotype, BRCA1 association, strong correlation up to 80%. Okay. So can you quickly revise this lecture quickly? Just a quick overview using this text, focusing mainly on the highlighted parts.
Okay, definition. Usually high grades. It's usually high grade tumor. Note to boost and nonsense. See diagnosis criteria. Statistical growth greater than 75%. High growth biological ATPI. That is also very common, which is well circumscribed. Sorry. Then circumscribed growth. Circumscribed growth, grossly and microscopically. The non-infiltrative epithelial component, which means no outside invasion to surrounding fat. Moderate to marked lymphocytic lymphocytes. Then high mitotic rate and tumor cells.
Okay. Strict diagnostic criteria. It must be high-grade cytologic feature from the 75% circumscribed, marked lymphoplasma cystic infiltrate. Atypical medullary carcinoma. Tell me more about atypical medullary carcinoma.
Which people act one or like does not have as similar architecture or morphology to medulla, but doesn't contain all of the features found in medulla. Uh, Invasive NSTD, the IDC NSTD medulla feature doesn't have all the features, but it has some overlap. Then prognostic atypical medullary carcinoma does not have the same favorable prognosis as in classic medullary carcinoma. Then in behavior and survival are more similar to high-grade invasive ductal carcinoma, not otherwise specified. So usually they are usually triple negative. Are you listening?
Yes.
Yeah, they're usually triple negative. ER, are 2 negative. They have basal-like molecular profile. That's CK56 EGFR, that the P cadherin.
Yes. So there's something we miss about atypical
Medullary.
carcinoma. It has the same prognosis as high-grade invasive ductal carcinoma. Medullary carcinoma type pattern is more favorable. Okay, continue, sir.
Okay. Associations and pathogenesis. BRCA1 mutation, BRCA1, medullary arterial strongly associated with BRCA1 carriers. So some often exist loss of the BRCA1 type allele, 10 mutations, other mutations, PTM mutations, P53 mutations. Molecular pathogenesis summary, okay, those mutations, okay, yes.
Okay. Why the prognosis is good despite high-grade histology?
Okay, high hypothesis rates, elevated expression of metastasis inhibitor metastasis inhibitor gene. Low expression of genes promoting metastasis. So maybe they usually doesn't have much susceptibility to metastasis. Intense immune responses. Enhanced tumor surveillance and destruction correlate with better chemotherapy response and survival. So then also immunotherapy. Immunotherapy.
Yeah, it goes with immune surveillance, yes. That's why I have better prognosis.
Jonah, let me not talk for a while.
Huh?
I will minimize my talking now.
Okay.
I'm trying to attend to a baby.
Okay. Yeah, I'm even those. I was even dozing. Let me just continue from there. So Societal growth 75%, prominent lymphoplasmacytic infiltrate, circumscribed growth. Um, Prognosis is favorable in classic medullary carcinoma compared to typical medullary carcinoma. Their basal-like and BRCA1 associations are very strong. The takeaway is that medullary carcinoma is a high-grade triple-negative basal-like breast tumor with paradoxical good prognosis if criteria are met. Behavior is shaped by its immune microenvironment and genetic underpinnings like BRCA1 than by its grade alone. Okay. MCQ questions. Which of the following is required diagnostic criteria for classic medullary carcinoma? Presence of no, treated no, without greater to 75%. Typical hormone receptor status of medullary carcinoma of the breast, triple negative, basal-like cancer. Which of the following molecular features is commonly associated with medullary carcinoma? Loss of BRCA1, wild type allele. Which of the following histologic features is not consistent with classic medullary carcinoma? Invasion into adipose tissue, lack invasion pattern, GG pattern. Atypical medullary carcinoma differs from classic medullary carcinoma by lacking one or more key diagnostic features. Does not meet the Rudolph criteria. Which genetic mutation is most commonly associated with medullary carcinoma? BRCA1. Which of the following is not typically expressed in medullary carcinoma of the breast? CD45, which immunophenotype marker supports the basal-like breast cancer phenotype? CK56, EGFR, and PIK adhering. What is the likely origin of what is the likely origin cell of medullary carcinoma despite its basal phenotype? Luminal epithelial precursor cell. Luminal epithelial precursor cell. Wow. Transcriptomic blood studies show luminal progenitor transformation despite basal phenotype. What explains paradoxically favorable prognosis of classic medullary carcinoma? Rich immune infiltrate by tumor-infiltrating lymphocytes and apoptosis genes. Which of the following is true regarding the prognosis of atypical medullary carcinoma? Is similar to high-grade invasive ductal carcinoma. What distinguishes classic medullary carcinoma from high-grade invasive ductal carcinoma? None otherwise specified. Prominent lymphoid infiltrate and pushing border. Classic medullary carcinoma has syncytial growth, circumscribed border, and dense tumor infiltrating lymphocytes. Which of the following is most commonly mutated in medullary carcinoma? P53 mutation. Which of the following best explains why classic medullary carcinoma is diagnosed less frequently today? Diagnosis criteria has become stricter. Pathologists now apply more stringent criteria, many classifying as many cases as IVC with medullary features. Okay. That's all for now. Let me see if I can. Mutations are P10 mutations, BRCA1, Y type allele, and P53 mutations. Next question.
Jordan,
Sir?
you're not stop.
Oh, I thought no, I thought you say you will not be talking. I thought you
Yes, I can talk now.
didn't tell me to talk. I thought you said you should not talk.
No, I don't want you to stop. Oh. I'm just commenting on you. Like
Okay.
I've been moving stuff. Now, then this tumor, the epidemiology,
Young people.
the young people. Which other tumor is also common in young people? Breasts, the
Is it
commonest.
what's it called? Micropapillary. Is it the
Nose,
basic micropapillary carcinoma? Which one?
secretive carcinoma. That's the commonest carcinoma, breast carcinoma in young women.
Secret carcinoma. Wow. I really forgotten. Secret carcinoma.
I didn't read this next question, I didn't read it. The one you just answered.
I've not answered it. I'm coming. Let me quickly. Secret carcinoma. It used to be called juvenile breast carcinoma before. But all right, it's good to let's even look at it. Breast cancers of young women. Common.
Maybe you might need to put variants.
Medullary carcinoma, medullary features.
Oh,
Secondary carcinoma. Medullary carcinoma is, you didn't know that medullary carcinoma is one of them.
okay, it's rare. Okay, maybe it's rare, but when you
Yeah, it's
see it
very
more
common. It used to be called
in
juvenile
young women.
carcinoma. Secondary carcinoma. It has the ETV6 NRTK. Ah! It's discouraging sometimes. It's really what I've read. Now we see it again. When you should have remembered it from the first go. Sometimes these things need constant repetition. And remember, the way you practice matters a lot too. The way you study, it helps you too in real life practice. I'm telling you, if you don't read much, you will not survive much too in real life practice. Let's look at this. So this is P63 negative. So
One of
what,
the funny statement regarding deletion, dependent
what the diagnosis?
is tubular carcinoma. Hmm? Sorry, no. When I saw this, it's not a carcinoma, so deletion is microgranular adenosis.
Diagnosis, yes.
The other tubular carcinoma is a differential.
Yeah, so
Okay, do you know the
how do you
clues?
black carcinoma from this?
Okay. Tubular carcinoma, tubular carcinoma. Can we do uh, PR? What will we say?
ERPR, I think will present tubular carcinoma and the rest.
Hmm?
PRPR present tubular carcinoma and hmm, I forgot it also myself, but I think I'll do ERPR. But let's see.
Do not arrive from this. Just sorry. The bland appearing by infiltration lacks microglial cell, also lacks sensitive with maybe it's going to be E.
Look at me. Oh. I thought that it was just they say which is the best answer. I didn't know that they say which is the wrong
It's
answer.
a set. It's
Okay, here is
E.
correct. Differential diagnosis includes sclerosing adenosis and tubular carcinoma.
That's true. Because both lack both
Yeah,
of them.
therefore collagen can be demonstrated around the tubular structures. Not sure. Intraductal and invasive carcinomas do not arise from this lesion. In,
That's a force.
mm, this bland appearing but infiltrating lesion lacks myepithelial cells and
That's true.
lacks reactivity with
But
epithelial.
doesn't lack the reactivity with GCD.
It's EMA positive, right? And
Is GCD FP15 positive?
and also
But
EMA.
lack okay.
We did this thing before. We've been differentiating this from tubular carcinoma.
Then this one has S100 positivities, right?
Yeah, it says 100 positive. Tubular carcinoma
Mm.
is 100 negative. It will be EMA positive, GACDP 15 positive. Ah, have mercy, God. Anyway, that's why I keep bringing the questions again and again to test us and make sure that we don't forget. Um, true. The typhoid collagen is true. The evidence of
Oh, do not arrive on this lesion.
yeah, it's become microgranular.
That is the force.
So microgranular is considered a potential non-obligate precursor to invasive breast cancer, particularly triple negative types. The usually it's not yes, it's false because they do arise. Yes, they do
Mm.
arise. I think the arise is
Mm.
going to be the basal type, basal type. You see basal cell type carcinoma, the triple negatives, right? That we mentioned at that time. The three of them being medullary carcinoma, there's two like that. I mean, the basal cell type was the one that's going to arise. Okay. So sad. Okay, we're gonna review it again. So sorry. So sorry.
Do you use
What?
Anki flash?
What's anti-plash? Eh? I get you.
Some people use it for exam preparation and studying. That it will tell you when to revise, like space repetition for studying,
What is that? Is it a software or something?
like a software.
What's the name?
Anki flash.
Anki.
Yes,
Oh,
Anki.
I never used it. I heard a lot about it. It's not for USMLE.
And people use it for listening. You can use it for many other things too.
Eh,
Like now, maybe if you are studying, I didn't know, but I didn't use it, but I know I am aware of the way people use it. If you are studying something, now you could say, remind me when so time. If you didn't get it at that time that you are doing the revision, it should not tell you again when you should revise it. Now, when you have now mastered it, it will now not be bringing it again to you frequently again.
How will you know what you are studying? Will you be studying alongside with you or what?
You'll be the one to be imputing it there. Oh.
To believe what?
To be put, you put what you are studying there.
Let's check it out now.
No, not now. I don't, I know that you use different kind of thing. So that's why I ask. I've not used it before.
I thought it's a company that is it AI flashcards?
Anki, A-N-K. Yes, this is it.
So I don't.
You have seen it before now.
I've never used it. I've heard some. I heard people have take flashcard or something like that. So how does it?
Uh, I really don't. I've not really used it before. I only hear people talk about it because of this repetition that we're doing. That's why it's come to my
Okay. So I'll be copying the things and putting there.
mind. But you may need to learn it some, to learn how to use it.
Okay. I think I will have to learn it then. I think I need it for this thing for exams. So that means I have to come out every time to come and check out the Anki.
Mm.
Is it that every day I read, I'll use Anki to read, or I'll be testing myself with Anki?
I'm not the right person to ask all this detail. I only have a vague idea because I've not used it before.
I don't even
I
have the
want, mm, maybe
but
I think there was a time I wanted to try how to use it, but looking complicated, so I just left it. That was many years ago.
um, okay, let's continue. Try it. So let's continue. So microgranular adenosis, it beats you again. It's rare, it's benign, composed of small round glands that infiltrate haphazardly into fibroadipose tissue. Single layer, they have basement membrane but lack epithelial cells. And you are right, they are triple negative. Sorry, oh, they're not positive at all. That's where to differentiate you from tubular carcinoma. I remember now. You remember now?
What's the profile?
This
That's
one,
luminal A.
I didn't get that. Yes, usually luminal A.
Luminal A. Yeah, positive.
Yes.
Uh, PR positive, are they?
ER
Then,
positive, PR positive, HER2 negative. That's
yeah.
tubular carcinoma. But tubular carcinoma is very low grade cancer. We don't normally upgrade it. Remember, there was a time we saw something like that. Normally it doesn't appear as high grade generally. All those videos. I thank God I recorded them. Understand? So it's going to be ERPR will help differentiate for tubular carcinoma. Microgranular adenosis will be S100 positive and triple negative. There's what we call it typical microgranular adenosis. That one represents a histologic continuum between microgranular adenosis and carcinoma. If you have architectural complexity, cytologic atypia, and carcinoma can arise from it. Pure microgranular adenosis is not associated with carcinoma. They may show copy number alterations, no genomic changes, no TP53 mutation, clonality is debated, does not metastasize. But atypical microgranular adenosis is associated with carcinoma, which occurs in 25% of cases, and is associated with TP53 mutations, copy number alterations. So the progression is from microgranular adenosis to atypical microgranular adenosis to carcinoma, triple negative
Yeah.
cancers. And there are some tumors that arise from these triple negative breast cancers of atypical microgranular adenosis. We used to know it before, adenoid cystic carcinoma of the breast, acinic cell carcinoma. Remember, I don't know if medullary is one of them. Adenoid cystic, acinic cell carcinoma, I think medullary carcinoma too. Usually grade 3 invasive ductal carcinomas. So histology, differential diagnosis include tubular carcinoma, which will have ER, PR positive, S100 negative, and dysplastic stroma. be angulated. Also, unlike this, that's not angulated with apocrine snout. Tubular adenosis will have microepithelial cells present. Acidic carcinoma will have zymogen granules, adenomyoepithelioma, epithelial and myoepithelial cells. Carcinoma arising from MGA. Age range is very wide age range. Palpable mass, female only disease. No known risk factors. The treatment is excision. No adjuvant therapy. Imaging and macroscopy. Speculated mass, the indistinct mass, ill-defined mass is very wide range, 1 to 20 cm. Low grade triple negative breast cancer from it is usually rarely fatal. High grade triple negative, can be fatal if it's metastatic. For pathologists, always confirm absence of microepithelial cells when diagnosing microgranular adenosis. AR negative status is in well-differentiated tumor should raise suspicion for microgranular adenosis. So if you have a well-differentiated tumor with a lot of tubules and you do ER/PR and it's positive, what will you think?
You have what?
A well-differentiated tumor, a lot of tubules, not almost 100% tubules, one layer, ER/PR positive. What do you think?
I think of microgranular adenosis.
No, ER/PR positive.
Oh, sorry, to black carcinoma.
Yes, ER/PR negative.
Microgranular adenosis.
Microgranular adenosis. And they examine the entire lesion to look for possibility of carcinoma. S100 positivity is something that would link you to it. You cannot that limited core biopsies may be difficult. MGA may mimic invasive carcinoma. So takeaway message is microgranular adenosis is a rare, benign, yet potentially pre-neoplastic breast lesion that lacks microepithelial cells and shows a triple negative S100 phenotype. While pure microgranular adenosis is indolent, it may transition to atypical microgranular adenosis to carcinoma, particularly in the triple negative spectrum. Pathologists must be vigilant in diagnosis. Complete excision and margin evaluation is important. So microgranular adenosis, tubules, this is another one. They have eosinophilic secretions. No desmoplastic stroma, just fat. What we see again in tubular carcinoma is that of desmoplastic stroma. Whereas in microgranular adenosis, you see it inside fat, no desmoplastic stroma. Do you understand?
Mm.
What's thing is S100 positive. This one is present.
S100, it should be nucleus thing, right? But at least look like a membranous.
Oh, let me check.
Okay, positive for nuclear and cytoplasmic S100. Okay.
Okay, look at the plasma S100. Yes, both of them are actually positive. Yes, right. You're right. This is ER/PR negative. This is the normal duct. Collagen 4 is present. P63 is negative here. Weak cytoplasmic immunoreactivity compared to the normal cells with strong P63. This one, P63 will be very weak. This is normal luminal cells. P63 is present. Cytokeratin is positive. This one is cytokeratin positive, or luminal cells, myoepithelial cells negative. Smooth muscle chain, smooth muscle chain, smooth muscle myosin heavy chain, negative in microgranular adenosis, positive in normal tubular cells. This atypical microgranular adenosis, they form solid nest of cells, greater nuclear atypia, mitosis, larger size of the net of neoplastic cells, you know, mitotic figure complex. They have stratification of cells. Secretions can become more scant for atypical micrograndular adenosis. Hmm. This S100. This tubular adenosis. This tubular adenosis are glandular cells that are going to be infiltrated into dense stroma. And the stroma will be sclerotic, but my epithelial cells will be present. You see, tubular adenosis is passive for my epithelial cells. Ischemic cell carcinoma can arise from microglandular adenosis. How do you know ischemic cell carcinoma on high power? Listen, how do you know ischemic cell carcinoma on high power?
They have granules, basophilic granules. Okay,
Yeah,
this one says eosinophilic
primary eosinophilic cytoplasmic granule, look at
or
granule.
apophilic. Yeah,
Ischemic cell carcinoma, that's one thing about them. It's lysozyme stain, positive. S100 is weaker than you see in microglandular adenosis. Adenomyopithelioma, they resemble microglandular adenosis, but they have two distinct cell types. What are the two distinct cell types? They have multiple layer of cells. They have luminal cells, and they have maybe muscles, myopithelioma. This is PCC3 in acetylkeratin E13. The tubules are composed of myopithelial cells. University tubular carcinoma is angulated. Secretions are absent. Can you say how angulated they are? Tubular carcinoma, very angulated. And then they are in desmoplastic stroma, unlike microglandular adenosis floating freely in fats. University ductal carcinoma will have, will be ERPR positive. How will I differentiate university ductal carcinoma from tubular carcinoma?
if you doctor from tubular,
Yeah.
uh, simple. Well, both of them. Um, EMA positive. Which one has? Yeah, which one is EMA positive?
I'm not sure. Low grade university ductal carcinoma from tubular carcinoma. Let's see if there's anything they can tell this solution.
Oh, that morphology can be useful.
Yes. the tubular, tubular intestinal carcinoma, you will have sometimes you may have it the tubules. You see tubules and solid and nested patterns. But this one, more than 90%. Tubular carcinoma definition by definition is more than 90% of small angulated tubules with open lumina, right?
Mm-hmm.
So upgrade universal ductal carcinoma will be round and irregular, where tubular carcinoma will be angulated.
Okay. Angulated, yeah. Non to irregular, the distance angulated opposite direction. The tubal shape. Apical knots.
Mm. The tubules are often less than 90% in invasive ductal carcinoma, whereas in tubular carcinoma, it's usually more than 90%. And remember that tubular carcinoma, is tubular carcinoma one of the basal cell cancer? No, it's not. It's just the H and E, less than 90%. The apical snouts and all that, and angulated this thing. But by AHC, I don't think it's very helpful. When invasive ductal carcinoma, you have areas that are tubules, cords, nests, solid and trabecular areas.
Mm.
Okay, so that takes us back.
After answering the question, the question on this one,
Mm.
I think we can end for now. Okay?
Okay, no problem.
Mm.
So, will you be available in the night or tomorrow?
Um, well, it depends. I'm going to work actually, so
Oh,
uh, if I'm out, maybe I will one or two.
maybe if I started earlier, I would have done 4 hours, but well,
I want to catch some rest before going.
no problem. It's okay. We're almost done with this case.
Mm. Okay, that's perfect.
So, can you review this one quickly? Then we'll now continue.
Okay, the rare proliferative lesion can mimic a facing carcinoma due to its inferior apparent lack of apparent cells. Clinically assessed due to it's not metastasizing.
Mm.
More onto over tubules or glands, single layer of blank tubular cells. Eosinophilic suspicion, no lobular organization. May appear infiltrates extending to adipose tissue or showing lobulated pattern. Then we have said that then membranes are intact, so showing type 4 collagen staining. Then Mr. Cello IEC provide S100 strongly positive, help distinguish it from tubular carcinoma. Parasantocarotid positive, confirm its epithelial cell origin. ERPR are two negative.
DNA
So,
negative, GCDP15 negative.
okay, this is the ERPR GCDP15 negative, EMA negative. Unlike
Apocrine
uh
differentiation. Okay, this is GCDP 50. GCDFP 15 is trying to look for apocrine differentiation.
yeah, the rule out applicant decision.
Mm.
The tumor applicant decision.
I think it's cynic has apocrine differentiation. What I
Yeah,
saw.
because of that secretion too, you want to rule out
Mm.
applicant origin.
Let's look at.
So tubular carcinoma is EMA positive, GCD F15, abi?
I'm not sure about that. Let me look at IHC's
Mm.
carcinoma. Sorry, IHC's for tubular. Sorry.
Yeah, pure positive.
EMA is not mentioned. That means not important. Let me see. What tumors of breast are positive for EMA or GCDFP15, right?
Mm.
Invasive, nothing so special. Apocrine carcinoma of breast. You see, apocrine differentiation. Apocrine carcinoma. Invasive ductal carcinoma with apocrine features. Anytime you're looking at something that's apocrine differentiation, go for GCDP15. Anyway,
Mm.
breast origin data 3. Yeah, let's continue. Okay. Polycystic fluid, polycystic disease fluid protein. Differential diagnosis. How do you differentiate microbial diagnosis from sclerosing diagnosis?
Architecture, lobotocentric in diagnosis. Both of them have look scarred, but
No, they don't look scarred, oh, but when
okay, 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 okay.
it's scattered. They don't
Scatter, scatter.
look scarred and bulocentric, concentrate around low.
Okay.
Understand? All that microbial diagnosis that is scattered in fat cells, dispersed in fat cells. It's not lobulocentric.
Mhm. Well, perhaps it's just present in sclerosis diagnosis, so it will be P63 and SMA positive. Negative in MGA. Typhoid collagen no diagnosis is surround the gland in MGA. Secretion may be present but less prominent in sclerosis diagnosis, but insulin secretion is common in MGA. ER status is positive, often positive in sclerosis diagnosis but negative in MGA.
Diagnosis in summary, we have epithelial cells and lobulocentric. Right?
Mm.
Differentially from tubular carcinoma, then tubular carcinoma.
Tubular carcinoma, the summary. Okay, the architecture contiguous infiltrative, scatter or lobulated,
Mm.
then also angulated and irregular, tubular, round, small uniform glands in MGA. Might be okay, absent in both. Typhoid collagen is
And that
absent
is
in
the
tubular.
architecture is contiguous in tubular carcinoma. While microbial diagnosis is scattered here and there, tubular carcinoma is contiguous, growing in one direction, like
Mm,
attached to each other. Continue, sir.
MGA is what? The scatter. So, my business is absent in both. Typhoid collagen absent in tubular carcinoma, present in MGA. Cytology myelotipia in tubular carcinoma, present in gland posting in MG. Apical snout is present in tubular carcinoma, is absent in MG. Then ERPR is positive in tubular carcinoma, negative in MG.
EMA. This is where you have EMA, the EMA we have been looking for.
Yeah, it's positive in tubular carcinoma, but it's negative in NG. Then S100, negative in tubular carcinoma, strongly positive in NG.
Mm.
So diagnosis of collagen. Topography outline the basement membrane. It
Now,
surround
the thing is
the
that even though there's no P63, you can still test further by doing type 4 collagen IHC. Its presence is like a surrogate for the fact that it's not invasive. The presence of, basement membrane will not be present in invasive cancer, but its presence still surrounding, the microbial adenosis. Continue, sir.
Okay. Oh, that's all. Clinical application, I can't see. LGA minor mimic carcinoma, but it's not metastatic when pure. So it's a non-obligated precursor of okay, that's another point. Sha. It's a non-obligated precursor of carcinoma.
Mm.
Existence can occur when LGA is diagnosed on core biopsy to rule out acute carcinoma, assess for atypical changes, possibly for carcinoma. Margins must be evaluated. Recurrence and ongoing to completed attacks. No systemic therapy is needed in pure MGA without carcinoma. So MGA is a rare benign but infiltrating lesion of the breast that lab material shares shows S1 depositivity, mimic carcinoma histologically and clinically, distinguished from sclerosis and cirrhosis and tubercle stigma through its unique immunological profile, lack of hormonal receptor, presence of typocollagen around to do. Though benign, MJ is non-obligate precursor to triple negative B-cell like carcinoma and should be managed with caution. Uh,
50 questions and we are done. We are done now. Why I look at
hmm? Do you answer question and postpone it?
hmm? Yes, quickly. Which of the
Okay.
following is true regarding mitochondrial adenosis?
It's true regarding my opinion. This lack hormone receptor expression
What is the typical histochemical profile of mitochondrial adenosis?
is 100 positivity, PC, P63 negative.
Yes. Which of the following physiologic features best supports diagnosis of MGA?
B. Round tubules, uniform tubule infiltrating adipose tissue.
Which histochemical marker is typically positive in MGA?
Okay, continue again.
Uh,
S100,
which stain is used to highlight the intact basement membrane around MGA?
typocollagen,
What is the clinical significance of atypical mitochondrial adenosis?
precursor to cancer,
Which of the following features help distinguish MGA from sclerosing adenosis?
my present in glands.
Which of the following features is least consistent with mitochondrial adenosis?
Which of them for MG? Okay, so least concern with MG, strong DNA positivity. You find that in tubular,
Yes. Which lesion may arise from MGA and display serous cytoplasmic granules?
eosinophilic cell carcinoma,
This makes cell carcinoma. Yeah. Is ethnic cell carcinoma positive for GC, gross cystic disease protein?
that is the question.
Gross cystic disease fluid protein 15. That's my goal. Yeah, because it has apocrine features. So EMA is even positive. Ethnic carcinoma has EMA, G6PD, even S100, PR will be negative. Androgen receptor will be positive. PS, that's another cancer that I've forgotten. So, but because it has apocrine differentiation, what is EMA? What kind of different? Okay, EMA is epithelial origin, actually. Continue. And question number 10. What is the most common mutation found in microglial adenosis associated with carcinoma?
No, come on to
Mhm.
TP53, common mutation,
Which of
MBS,
the following helps distinguish tubular carcinoma from MGA?
S1. Oh, okay, yeah, PR positivity.
What should be done if MGA is diagnosed on a corneal biopsy?
Complete excision evaluate arterial carcinoma.
What is the significance of eosinophilic luminal secretions in NG?
Benign secretory product false positive.
And that stage resistance. Which of the following markers is not useful to confirm the epithelial nature of MG?
Which of following
Most
best
useful, most useful, sorry.
to confirm the nature? Vasoconstrictor kerosene.
Which of the following best defines the relationship between MG and carcinoma?
None of the KP.
Thank you very much for your time. Today was very productive. We didn't finally, you didn't just waste like the last 2 days.
Okay.
Thank you, sir. Let me know what.
You're welcome. Stay along with me. I'm applying for you. I've first put application for pathology job here.
That means you have to study more.
Yes, I have to study more. I've experienced some rejection, but I'm still open. As some that I'm still waiting that I've not given feedback.
Okay. Did you apply with part one result?
Yes, and my full license. I'm registered already.
Okay.
And
Okay.
then after passing club, I'm already at the
Yeah.
license to
After passing
practice.
part one, did they give any certificate to show that you passed part one?
They don't give it, yes, just like an evidence of passing. Like a
Okay.
letter.
Okay. Okay now. Take care, sir.
Oh, well,
Okay.
thank you.